Welcome back. I'm the Intense MD, a double board certified intensivist, here to give you an inside look into the intensive care unit. A couple weeks ago, I put across a call on all of my social media platforms for your questions for me, an ICU doctor. So, this is a compilation of your questions from YouTube, TikTok, and Instagram. So, let's get into it. First, we'll start with the questions asked on my YouTube community page. First, I was asked if I can do a video about wound vacs, and I can certainly make an entire video about wound vacs, but I'll tell you a little bit about them right now. So a wound vac is usually used in a significant wound. Many times it's used in surgical wounds, particularly those that they are not able to close due to a lot of swelling. So there are three components of a wound vac: the foam dressing, a clear adhesive film, and the vacuum pump. So the vacuum uses negative pressure to remove excess fluid from the tissue as well as help promote blood flow to that area. And this helps accelerate wound healing. So, accelerate wound healing is one of the benefits of wound vacs. They also minimize scarring and prevent infection. But like I said, I'm happy to make a longer video about this topic if you want to hear more about it. The next question was asking why we need to use our badges to scan in and out of places in the hospital. And they gave the example of what if you were in the MRI suite with your child and the other people left the room and you're not able to get out. So there's a couple components to this question. One, the badging in and out of areas is so people don't end up in places that have restricted access or, somewhere they don't belong, particularly if if the hospital is open access, then people might accidentally end up in sterile environments such as the OR. It's also for patient safety and staff safety. If any of you have been to labor and delivery, you know that this is a highly secured unit as well as the newborn nursery to prevent kidnappings. Unfortunately, there are attempted kidnappings at hospitals. For the MRI in particular, this is definitely a safety issue. So, the first word in MRI is magnetic. It is a giant magnet, and the magnet is always on. There have been multiple instances, and you can Google MRI accidents where things have been pulled into the magnetic field. And unfortunately, some people have lost their life because of MRI accidents. So, particularly in the MRI suite, they want to make sure that only authorized personnel are in and out of that room, the safety issue with that equipment in particular. So the hospital has many different areas where the average person would not be safe if they don't know how to treat that area properly. And then again, the in and out can be also a patient safety issue or a security issue. The final question on YouTube is, how do I prepare myself for the ups and downs of my job and how do I cope since I do have a high stress job? One of the things that I adopted pretty early is reminding myself that I did not make these people sick. I am here to help them and I am doing my best to help them. I do see some very sad situations. I see people in crisis. I see people in very emotional times, but I see myself as a support to them. If we have a particularly emotional case, sometimes the staff members lean on each other because we all feel it when there is a very difficult, sad situation. But we also do help a lot of people. We do see people leave the ICU and leave the hospital, and some patients even come back to say hello and let us know what they're doing with their life since the ICU. So those moments also help us continue to deliver care to the people who are currently in the ICU because we know what the other side looks like for them as well. I also make sure that I leave work at work. I try to finish all my documentation before I leave the building so I don't have to log into the electronic medical record at home. So when I reach home, that is my time to decompress and have to myself. There will always be those couple sad cases that stick with you. But overall, I think that what we do in the intensive care unit does benefit people. And of course, I also have a number of hobbies and interests outside of medicine. This helps me live a well rounded life and I don't just fixate on work. Next, we're moving on to TikTok. The first question was, what do I feel is the most helpful information to the general public, and what are some misconceptions about the ICU? So, for the first part of that question, I'm going to refer you to the most recent live that I did. It is called the ICU and You, and that is an entire live about what I think the average person should know about the intensive care unit. Some of the highlights were talking about what life support is, what a code status is, and how to select a medical decision maker and who your default medical decision maker would be if you do not have an advance directive. Misconceptions about the ICU, I think there's a few that I can think of off the top of my head. One is that there are only old people in the ICU, and that is not true at all. There are many young people in the ICU, especially trauma ICUs. Many times it's people in their 20s and 30s who get into tragic accidents and end up needing ICU level care for their injuries. I've taken care of many patients my age or younger, so it is not just a place where older people go or elderly patients go. There are patients of all ages in the intensive care unit. The next misconception has to do with code status, and that's that do not resuscitate does not mean do not treat. If somebody is a do not resuscitate, this means that they do not want CPR or shocks, anything in terms of resuscitation if their heart were to stop on its own. Many people who are a do not resuscitate are accepting of certain life support devices and strategies. That's why it's important to know what you want as a whole in your medical care, because some people might not want anything, but some people do want all support and treatments offered up until the point where their heart stops on its own. And they feel if their heart stops on its own, that's the sign that their body is too weak to go on and they don't want an attempt at resuscitation. And the final misconception that I can think of right off the top of my head is that many people think the ICU is where people go to die. Nobody survives. We have a 100% mortality rate, and that could not be further from the truth. Because if you think about it, what would be the point of doing this to somebody if there were no benefit? Unfortunately, we do have a higher rate of mortality than the rest of the hospital because of critical illness. But there are people who do survive the ICU and, after being on life support for a period of time, go on and live their lives. Next question. What are some common reasons why someone would go to the intensive care unit? So there's many diagnoses that can lead you to the intensive care unit, but I bulk this into, is the patient on life support? Do they require continuous monitoring, or do they require an ICU level of nursing? Whether that means that they need aggressive monitoring or hourly checks, such as hourly neurological checks, hourly glucose checks, hourly vascular checks. So, all these things are broad categories of why someone would need to come to the ICU. Some of the more common diagnoses are respiratory failure, sepsis, heart failure, stroke. And like I said, there are many reasons why someone would need to come to the intensive care unit. Those are some of the most common diagnoses that we could see and some of the broad categories that these can be placed into. The final question from TikTok is, how much time must elapse before critical organs can no longer be harvested? Is there a way to screen organs of ICU people at the time of their death? So once a patient is deceased, their organs are no longer able to be considered for donation. The decision for donation needs to happen before that patient has died. So if somebody has died without being considered for organ donation, then unfortunately they are not considered a candidate for donation anymore. Typically, patients who are being considered for organ donation are those with significant neurological injury or people who have a low likelihood of surviving. One of the main things that excludes a patient from being an organ donor is multi-system organ failure, which is a common diagnosis in the intensive care unit. I made an entire video about the organ donation process as part of my organ failure series, so if you want to learn more about this, you can check it out. But in terms of what I think that person was asking, the way I interpret the question is how much time after somebody dies you have to harvest their organs. And if they are not already screened and entered into the organ donation system, then the screening process cannot start after death. If that person was already planned to be a donor, the family had already consented to it, and the organ donation group is already standing by, then as soon as the patient has cardiac death, it is proceeded with the harvest process because, again, it is time sensitive. For donation after cardiac death, which is a particular type of donation process, and it's pretty rare, I'd say brain death is a more common route to organ donation, then there are certain time constraints, and that depends on the organ. One time I was taking care of a patient who had planned for donation after cardiac death, and her kidneys were able to be donated. And the nurse that was working with the organ donation group told me that the patient's heart had to stop within 90 minutes or the organ was no longer considered viable to donate. So that's it for the TikTok questions. So I'm going to move on to Instagram. First question on Instagram was, do I suggest critical care medicine for internists? So internists are those who have completed internal medicine residency. That is what I did. And I think critical care is a very good career for people who enjoy internal medicine. It's pretty much internal medicine with more critical illness, sicker patients, and bedside procedures. If you do not like bedside procedures, then I would not recommend critical care because we do many procedures in the intensive care unit. It is a procedure heavy specialty. But if you like complex thinking and problem solving, then that's probably why you went into internal medicine in the first place. The ICU allows you to do that in the setting of organ failure. The next question is, how are the responsibilities of a patient shared between physicians and nurse practitioners or PAs? So we do utilize PAs, physician assistants, and nurses in the intensive care unit, particularly the ones that I've been working in, and we share the patient load. Typically, they will see the patients who are ready to be transferred out of the intensive care unit or patients with lower acuity. Sometimes they'll also help with bedside procedures. At one of the hospitals that I worked at, the nurse practitioners would be on the rapid response team. So they would be the first to go assess a patient on the floor, and then they would call the physician if they needed backup help or if the patient did need to come to the intensive care unit. So there was a lot of teamwork involved in the ICU and particularly within the critical care team, but we do split up the duties depending on the acuity of the patient. And the final question from Instagram is, how large are the ICU teams and who is typically involved in the patient care? So I also made a video about this some time ago, but the ICU teams can be fairly large depending on what type of unit you're working in. And we may not necessarily round with the entire multidisciplinary team, but there are multiple people involved in one patient's care in the ICU. You typically have the physician, either a physician assistant, nurse practitioner, or sometimes some trainees, such as a fellow or resident. You also have the patient's bedside nurse, respiratory therapist, dietitian, social workers, case managers, speech language pathology, physical therapy, occupational therapy. Typically, those groups take care of most patients in the intensive care unit, and then additional people who may be consulted on the case. We may also have the palliative care team come, other medical consultants such as cardiology, nephrology, infectious diseases. Also have medical ethics team come by if there is a complex ethical dilemma. So thank you to everybody who has submitted a question for the Q&A. Thank you to everybody who has submitted questions for this Q&A. You can ask me more questions in the comments below. Keep an eye out on my YouTube shorts because sometimes I will answer brief questions there, but ones that need a longer format video, of course, will show up on my main feed. If you enjoyed this video, give it a thumbs up or let me know if you like this format, and I will see you next week with the next video.